Committee, thank you. Sorry about that. Committee, I do want to bring your attention to a couple of things we've had some issues with. Over here, click on participants. And for those that don't know how to raise your hand, move your mouse over your name and a hand will show up. And then I can see that. So anybody have any problems with that? Let me know. But yeah, if you go, like if I go to, you're not on here. I guess maybe I can't do it on somebody else's, but I can mine. See, so that's what you do. So you just have to go. It won't raise anybody else's hand, but it'll raise yours. So you just go like the mouse over your name. Yep, and there's my hand raised. See, and then when you take it off, it's not. So. Okay, very good. Everybody clear on everything that they need to be doing there? All right, very good. We're going to go ahead and start the meeting. We'll start off with Georgiana.
Mr. Chairman, it's Scott Bruner with KDADS. I wanted to just, Georgiana is going to present first. I just wanted to mention that Janice DeBoer was going to present. She's had a little health issue, so she's been out the last couple of days. So Georgiana's pinch hitting, but you're in very capable hands. And then I'm going to share my screen and drive the slides for Georgiana, and then do my presentation when she's finished.
Very good. Thank you.
Georgiana, you're muted.
I'm so sorry. I thought I shut that off. My apologies. Good afternoon, Chairman and committee members. It's nice to see you all again. My name is Georgiana Correll, and I am the Facilities Program and Finance Director at KDADS. I'm going to present a high-level review of the nursing facility program and then turn things over to Scott Bruner to present the remaining slides over survey and certification. So the nursing facility program oversees Medicaid enrollment, change of ownerships, reimbursement rate setting, auditing of cost reports, the quality care assessment, CMS enforcement, the ventilator program, Peak 2.0, and nursing facility regulations. Next slide, please. There are currently 328 licensed nursing facilities in Kansas, and of those, 96% or 316 facilities participate in Medicaid. The below tables represent the Medicaid participating facilities by region on the left, and the average monthly census for Medicaid participating facilities as of Q1 of state fiscal year 21 on the right. Next slide, please. Nursing homes are reimbursed for Medicaid resident care using a facility-specific cost-based prospective payment system. You can read more about this in CAR 129-1018, which is the regulation specific to reimbursement. But costs are submitted via cost reports annually in February from each facility. Inflation is then applied to these costs utilizing the Global Insight Skilled Nursing Facility Basket Index. An average of 3 base years are utilized in the calculation. And there are 3 cost centers: operating, indirect health, and direct health care. Upper payment limits are applied to cost centers and property ownership costs. There are also add-ons applied for incentive performance, the quality care assessment tax, and property ownership. Case mix adjustments are also applied semi-annually for July 1 and January 1 rates. The January 1 and April 1 case mix indices are averaged to set the July 1 rate, and the July 1 and October 1 case mix indices are averaged to set the January 1 rate. Next slide, please. To develop the per diem rates, the total reported costs from cost reports are adjusted through desk reviews performed by KDAD's audit staff, which provides the total adjusted costs for each facility. Inflation is then applied to the total adjusted cost for each of the cost report periods, which then gives us the total combined costs. These combined costs are then divided by the resident days or the 85% occupancy rule, which then gives us the per diem rate for each facility. The parameters used for state fiscal year 21 was cost report data from 2016 through 2018. Inflation from the midpoint of the cost report year was inflated to 12/31/18. And the upper payment limits were reset based on the updated cost data. And the incentives were calculated based on the 2019 cost report data that we received. Next slide, please. Oh, sorry, before you switch, currently our average daily per diem for state fiscal year 21 is $197.50. Now, next slide. So this slide provides a little detail on our PEAK 2.0 program. PEAK stands for Promoting Excellent Alternatives in Kansas. PEAK started in 2002 and was revised to PEAK 2.0 in 2011. This revision made PEAK 2.0 a Medicaid Pay for Performance Incentive Program, which focuses on 5 domains essential to person-centered care. Those 5 domains are foundation, resident choice, staff empowerment, home environment, and meaningful life. Currently, there are a total of 6 levels, and each incentive level has a specific pay for performance incentive attached to it, in which homes can earn by meeting defined outcomes. Currently, there are 134 facilities participating in PEAK, which is about 42% of all Medicaid participating nursing facilities. And with that, I will stand for questions.
Questions? Representative Howard.
Thank you, Mr. Chairman. My question is, you have 0 through 5, and you show a parentheses of 50 cents, 50 cents, about 2, 2.50, and 3. What do those mean? Is that per hour, per
That is per day. That is per day per resident. So if you are at 0, the foundations of person-centered care, you're going to get a 50% or 50 cent add-on to your rate per day per patient. Is how that works. Now, just to be clear, the level 5 is $3. So you don't get 50 cents, $1, $2, $2.53 all added together. It's not cumulative, it's individually. So once you get to 5, you will now get a $3 incentive rate.
Okay, thank you. Thank you, Mr. Chair.
Any further questions? Okay, very good.
Okay, well, I'll now turn things over to Scott Bruner to present the remainder of the slides. Thank you.
Thanks, Mr. Chairman. Thanks, Georgiana. I think she'll stay on for a bit if other questions come up. So Georgiana presented the program side of nursing facilities that KDADS is responsible for. The other role that we have in the long-term care setting is licensing and surveying of long-term care facilities. Janice DeBoer, Deputy Secretary Janice DeBoer, oversees the program and policy side, where Georgiana works in rate setting and other parts of that. I oversee the survey and certification and the licensing components of the nursing facility programs and other long-term care settings. So that's why I'm presenting this part. So we wanted to just capture for the committee kind of the kinds of homes that we're talking about. This has come up a lot in the last few weeks as we've been talking about vaccine and testing and kind of what facilities do we mean when we're talking about long-term care in Kansas. So the statute that lays these types of facilities out is KSA 39923. And that defines a group of facilities called adult care homes. And within that category of adult care homes are all of the things that you see on the list here: nursing facilities, assisted livings, things we call home pluses, adult daycares, residential healthcare facilities, private psychiatric hospitals, psychiatric residential treatment facilities, and then we also license community mental health centers. They're not adult care homes, but we do license them as well as substance use disorder treatment facilities. So when we use the word adult care home, everything on this list above the community mental health centers are the kinds of facilities that we're talking about. The commission, the Survey and Certification Commission that does this work is involved in writing regulations and enforcing those regulations around the quality of care that folks receive, and making sure that any applicable state or federal regulations are followed. We do that largely through on-site surveys. We go out into facilities and look at a variety of different things depending on whether they're following a CMS, federal Centers for Medicare and Medicaid Services set of requirements, or whether the requirements are only based in state law and regulation. We also receive through our complaint hotline concerns that residents or family members could raise about abuse, neglect, and exploitation. We take those complaints and then investigate them as quality of care issues or patient safety or abuse and neglect complaints, and we do those largely in person as well, but some of them can be handled by phone. And then we also license and certify several different health occupations that work in these settings, like certified nurse aides, CNAs, CMAs, which are certified medication aides, with a slightly higher level of skill, nutrition assistants, home health aides, and then we also license operators of nursing facilities and other skilled settings as well. Let's see, the last kind of paragraph on this slide talks about our role in COVID inspections as well, but I think I can talk about that a little better on this slide. So I mentioned to the Bethel Oversight Committee, for those of you that sit on that group, that we were involved since the beginning of the pandemic, directed by the federal government to conduct infection control surveys in long-term care settings. And then in House Bill 2016 that you approved last session also directed us to conduct similar kinds of infection control surveys in the state licensed adult care homes that we regulate. And as of September, we started that activity late April for federally certified facilities, and more into May and June for state license. But by September 23rd, we completed all of those surveys. So we physically entered every facility in the state that we regulate and did an infection control survey where they participate in the federal federal Medicare or Medicaid programs. There was a federal template to follow, and we had a similar template to follow for the state licensed facilities. And so that was well over 500 facilities that we entered and conducted those surveys, and we can talk more about what we found from those if you have questions about that. We do have a plan to return to kind of our regular survey activity. So typically we're trying to do a regular annual survey in most facilities, and we're trying to get back on that schedule as we have time. There are a couple of intervening factors, COVID being one, and then direction from the federal government to conduct some other surveys as well. But so right now, what we listed on this slide are what our priorities are from the CMS direction. That's federal infection control surveys, complaint investigations that have a high enough concern that there might be immediate jeopardy of a resident, or a resident might be in immediate jeopardy of harm. Special focused facility surveys, which means we need to go in and look at some particular aspect of that facility, and then in facilities that haven't had a regular recertification survey in 15 months. So we're building those schedules out now through the spring to get kind of back onto a regular routine as those infection control surveys were completed. For the state licensed facilities that don't have the federal requirement, similar kinds of activities we're trying to get back on schedule for annual licensure surveys and complaint investigations, of course, as part of our routine activities. This is another area where there are new facilities that are coming online. either renovated space or entirely new facilities. So we have to do an initial survey, and that's part of the priority there as well. So that's the overview of the nursing facility program that the committee asked for. Again, very high level. We'll be back in a week or so, a couple of weeks for a budget overview. We can talk some more about that, but happy to pause here and take some questions, or I can jump into the state hospital overview and then take questions at the end, or happy to follow your direction, Mr. Chairman.
Committee questions. Representative Concanon.
Thank you, Mr. Chairman. Scott, I've been asked a question. I can't find the email right now, but so the state is paying the nursing facilities for COVID testing through the end of January. I think that's what I was told. Do you know if there's any plan or intent that will continue?
Sure. So as part of the statewide testing strategy, there was from the Office of Recovery a grant of CARES Act money to pay for testing in for everybody in the state, and that included long-term care settings that didn't have another payment source or access to testing. That was scheduled to go through the end of January. My understanding is that that's going to continue through February. I think the program is changing a little bit to allow that was done through regional vendors or regional labs that are conducting the actual testing in different counties or different groups of counties by region. Before now, they weren't collecting insurance information if that was available to see if somebody that needed a test had insurance coverage for that. They're going to start collecting that information so they can bill insurance where it's available. But my understanding is that there's going to be ongoing funding for that testing at least through February, and then there's some other efforts to identify other either leftover CARES Act money that was unspent or other resources to continue that testing for longer than February.
Great. Thank you, Scott. Thank you, Mr. Chair.
You're welcome.
Representative Ballard.
Thank you, Mr. Chairman. Scott, I'm looking at like the survey and the certification, and we have had problems over the years, especially in our CanCare oversight about surveyors. I don't know if you're the right person at this time for us to discuss it, but how do we stand on the number of surveyors? Because we were behind.
Mm-hmm. It's been an unusual year. That's probably the answer you get a lot. So we are, I don't have today how many vacancies we've got on the survey team. We usually hover around 15 or 16 vacant positions to be able to provide coverage throughout the state. Our nursing facility surveyors are, they're divided into regional teams with regional managers. So we've got better coverage in some regions of the state than others, but the team works really well together to make sure they're getting all of the work done. So as we had to complete all the infection control surveys, and now looking at some of those surveys that are getting close to their 15th month and needing the recertification, the team's really working across the state. So I think we're around 15 vacancies on the nursing facility side. For state licensed facilities, the assisted living, home pluses, those kind of settings, our teams are smaller. I don't think there are as many vacancies there. There may be one or two, but I'll get the exact number. And we're working on again verifying what the frequency is between surveys. But it's we got all the infection control surveys done, which was a monumental amount of work, and I think it pointed out areas where we can be a little more efficient and directed so that we can keep up with the regular interval. But it just that the teams are a little different by function. But I can have that for the budget hearing, certainly how many vacancies we've got on each team.
Okay, that's very helpful. Thank you very much. Thank you, Mr. Chairman.
Committee, further questions? No one online. Scott, could you back up to your first slide? There. No. Your first slide.
I'm sorry. I think that was the first, the one I started with.
That one. Okay. Do you have any numbers whatsoever? I understand it's pretty fluid, and do you have any numbers in how folks that are served by the various types of facilities?
In terms of the number of residents in each
Yes.
one, Chairman? So that question comes up a lot. On the nursing facility side, we have a little better insight into the data to know relatively current census counts. For the others, for the state licensed as a broad category, we know how many beds we've licensed in each facility, but we don't necessarily know what their occupancy rate is. So we could pull that together for you and get that back to the committee of how many beds are licensed in each category and what we know about occupancy. But we don't have as good a data on the license side as we do on the nursing facility side.
Yeah, I think it would be good for you to provide us any information you can along those lines.
If I was smiling or laughing, I've gotten that question multiple times this week, and it should just be right at the top of my head, and it's not today for some reason. With vaccine, that's a question that's come up quite a bit in the last couple of weeks.
Sure. Any further questions? Okay, thank you, Scott. And
I will transition over here to the hospital slides. Give me just a second.
we need to extend this meeting out as long as possible till at least 5 o'clock. So.
We may be successful if I can't figure out there.
Because of how painful it is for me to let you guys go early.
Georgianne was reminding me, she sent me a spreadsheet with the census counts on it last week. So again, I know it's top of mind. I apologize for how many things I can remember at once. Mr. Chairman and members of the committee, I'll introduce myself again. So different part of my role is working with our state hospitals. And you asked for an overview of the 4 state hospitals as part of this presentation. So I'm going to do that. If I can get the slides to advance. The Kansas has 4 state hospitals that are, you can see where they are on the map here. Kansas Neurological Institute and Parsons State Hospital and Training Center are 2 hospitals that serve people with developmental disabilities. And then Larned State Hospital and Osawatomie State Hospital are 2 state psychiatric hospitals for adults. And you can again see where those are on the map in case I was trying to find the welcome slides or the signage pictures that we have on the website, but the map was a better, I think, visual for that. KDADS has administrative responsibility over the 4 state hospitals. They report to Secretary Howard for that role, but each hospital is its own state agency. And so in your budget role, you'll see budgets from each of these 4 hospitals that in addition to the work you do for KDADS. The superintendents of each hospital are the agency head. And then there are some parts of those responsibilities that flow under the Secretary of KDADS as well. And then I'm, as the Deputy Secretary, delegated some of Secretary Howard's authority to help oversee and coordinate for the hospitals. Within KDADS, we have something called the State Hospital Commission that I also oversee, that works on some of the coordination activities that we need for the state hospitals. There are a number of activities. They're each separate state agencies. They have their own functions and they're unique in their own ways, but there are some things that are in common. They all submit capital improvements plans for your consideration and for state oversight. They all, different degrees are involved in the Medicaid system and receive funding through that program. They all have a risk management responsibility as part of their licensing and credentialing and certification process that's similar campus to campus. And then they do have some contracts that we share for efficiency's sake, that we bulk purchase some activities. And for example, our food service contract between at Larned and Osawatomie is a single contract that serves both campuses. So where those things overlap, KDADS works through our hospital commission works to coordinate those activities to make sure we're moving things through the state procurement process, that we're plugged into the governor's budget office, and providing support to the campuses for those common activities. But they are independent agencies, and you'll see their separate budgets, and the superintendents certainly are the people on the ground doing the work every day. And so when we get to that point next week with the budget, you'll hear from each superintendent, and they'll share their experience, what their initiatives are and priorities are. And you'll see some common themes, but there are, again, things unique to each campus. For the two intellectual disability hospitals, KNI and Parsons, they're designed, their mission is to serve people that have severe, lifelong intellectual and developmental disabilities. These are individuals that live on the two campuses that generally are going to require lifetime services and supports for intellectual disabilities that they have had since birth or early childhood, and so they have different kinds of needs than folks at the state psychiatric hospitals. Both of those hospitals, KNI and Parsons, are surveyed by the Kansas Department of Health and Environment as intermediate care facilities for people with intellectual disabilities. So their survey function is, or their survey activity is similar to what KDADS does for long-term care settings, but that's performed by the Department of Health and Environment. They all use a person-centered care planning process that's very specific to each resident to find what they need and enjoy, and how to have the best life that we can work for those individuals that live on our campuses, to try to include them in community activities as much as possible. A lot of that's changed with COVID, and you'll hear about that when the superintendents talk, but it is a very person-centered planning, person-centered treatment environment at both campuses. We wanted to give you a little bit of information about the number of beds and the census and staffing. So you can see on this slide, KNI is budgeted for 132 beds and Parsons has 188. And what the census numbers are right now. Parsons also is the home campus for a reintegration facility for the sex predator treatment program, and so that is included in their bed count. So those aren't people with developmental disabilities, but it does give you a sense of the numbers there. Our census is down. If you would have looked at these numbers last year, we've had more deaths both at KNI and a couple at Parsons as well. Some COVID related, many not. Just there at KNI in particular, our resident population is very frail and aging, and are succumbing to diseases of that nature. And COVID certainly hasn't helped. But our census is down a bit. For staffing, each campus has about 450 staff that serve the people that live on each campus in terms of authorized positions. Typically or often, you've got questions about the turnover rate or kind of the employment nature of each campus. So we wanted to provide you the turnover rate and vacancy numbers for both campuses. At KNI, our turnover rate's a little over a third of the staff annually. In Parsons, it's about a quarter. and our current vacancy rates are a little better at KNI. They've had a good recruiting year this year and retention, and Parsons is a little bit higher. Again, some of that could be the nature of the communities in Topeka. The workforce tends to be a little bit more, turns over more, so we can hire and fill positions a little bit easier than we can in Parsons. But we can talk through more of those numbers as if you have questions. Didn't want to go too much into the budget for this purpose, but the hospitals in general, actually all 4 state hospitals, their funding comes from either the state general fund directly, from Medicaid payments that are either directly paying for services for people on the campus, or through the disproportionate share program, which is a funding stream in Medicaid that pays for people that are uninsured and tries to meet some of the costs for hospitals that serve a number of people that are uninsured. All of that Medicaid revenue is deposited into one parent account that's managed at KDADS and then distributed to the campuses. And you can see the kind of how that flows back and forth. Again, that's one of the roles that we try to provide through the commission to sort of keep that straight and lift some of that load in working with the Medicaid agency at KDHE. For the state mental health hospitals, just at a high level, Osawatomie has two hospitals in one. There's the Adair Acute Care Unit, that's the Medicare certified area, and then the Osawatomie State Hospital is the more long-term care area, and then Larned. But they all, 2 or 3, however you want to think about it, serve people that have serious mental illness, and that's interfering with their ability to be safe in the community. Both campuses, both hospitals serve people who are deemed to be a danger to themselves or others. That could be through a court process where they're found to be in need of care, or through a screening process that happens with our community mental health centers to identify people that are in crisis and in need of an inpatient level of care. Once they're stabilized at the state hospital, many people, most return to their home community and get community-based treatment through their mental health center or local provider. Both the Adair unit at Osawatomie and Larned Psychiatric Services Program participate in Medicare and Medicaid, so they can bill for the services that they provide to those to the federal program Medicare and the state and federal partnership in Medicaid. And they do provide a wide array of mental health care and treatment to all patients that are there on the campus, including mental health care, occupational therapy, activity therapy, those kinds of things as well. It's a full service hospital. Although there are some limits on the kinds of medical services that we provide. We don't provide ventilator levels of care. If somebody needs long-term dialysis, that's a challenge as well. But in terms of the mental health services, it's a one-stop hospital. Those are both one-stop hospitals. Larned's also got 2 additional programs that sit on the campus in addition to the psychiatric services program. Sexual predator treatment program is on the Larned campus in 2 or 3 of the buildings that are available there. We call it by the acronym SPTP, but the Sexual Predator Treatment Program serves people who are civilly committed to the state's custody that have served their criminal sentences for crimes that they've committed of a sexually violent nature, and they're determined by the courts to need ongoing care before they're released. We do provide treatment to those individuals that are civilly committed, and other services that they need to help them transition from the correctional setting into the sexual predator treatment program, and then eventually community reintegration when they've completed the treatment program, to show that they're safe to be reintegrated into the community. The state security program is also on the Larned campus. This is where we treat folks that are referred by district courts that need a forensic evaluation. So if a criminal offender is determined by the court to need a competency review to see if they're competent to stand trial or if their competency can be restored so they can stand trial. Those folks are sent to the state security program for that treatment. It also houses our security behavior unit that if we get a patient that is violent or aggressive beyond the needs of and not safe to be around other patients in the treatment unit, we can move into the SBU to get that higher level of care. Again, similar slide about the budgeted beds and census, lots of acronyms, which we'll clean up before the budget hearing, but Osawatomie's got 114 budgeted beds in the long-term care part of the hospital and 60 in the Adair acute unit. The average census, particularly on the Adair units, down a bit. Largely because of COVID, we've reduced the capacity there a bit to have single rooms so that we can keep people isolated. But that's a little bit down from last year. At Larned, PSP is a psychiatric services program, the state security program, SSP, and then the sexual predator treatment program. And you can see the numbers there. In terms of authorized positions, again, Osawatomie has 490, about 500 employees. And Larned's got a little over 900 employees to serve that campus. And that's, again, across all of the programs, the psychiatric services, sexual predator treatment program, supported facility, the full operation. In terms of turnover and vacancy rates, Osawatomie, again, since it's in the Kansas City metropolitan area, the turnover rate tends to be a little bit higher. They're able to fill positions often, so their vacancy rates a little better. And Larned, overall, the turnover rate's not quite as high, but we've got a lot of vacancies. We'll talk about during the budget overview the funding that and the focus that the governor put on the Larned pay rates through an executive directive a couple of years ago. That's had a really good impact on these numbers over time. The trend's certainly moving in the right direction. But we could certainly talk more about vacancies and placement and turnover as we get more into the budget. The next group of slides, I did want to respect your time, but then you said I could get you till 5. So I don't want to go through all of these because we'll go through some of them in the budget. But if you want to look through the slides in more detail as you have time to do that, we tried to include a little bit of information about the nature of the populations at each campus and some of the initiatives. I might just skip ahead to the last slide in the deck, number 22, and highlight for you just 3 of the issues that we're facing that you'll hear about during the budget cycle, just to kind of talk about in a general sense sort of issues that we're facing at the hospitals. I didn't put anything about COVID on here. The superintendents will talk more about that as well when we get into the budget.
I think we do have enough time to go through those slides.
Oh,
so,
okay.
Yeah, 5 o'clock, that's 45 minutes.
Usually people get tired of listening to me talk, so I didn't want to presume.
No, and you know, committee, I know I joke around a lot, but I'm just telling you that you're going to hear a lot about this. So just a couple of points about each campus, just to give you some more of the context. So at KNI, there's 133 people that live in 20 different homes. The functional unit at KNI is the home, and they're in 4 different buildings. So within, I think it's pretty evenly divided. Within one of the lodges, there's 5 separate homes that are functional units. The people that live in that home, identified home, they have meals together. They have common time together. They've got a day room together. But so instead of it being as much of an institution or maybe what you would envision as a state hospital, the attempt has been over time to develop more of a home-like community setting with smaller units. There's smaller groups of residents with a dedicated staff that serves them in their home. We still use the same buildings, but they're just divided into different functional units. 94% of the residents are categorized as having a severe or profound
intellectual disability. Um, and again, these would be lifetime disabilities that they've had since birth. And then what I always have found that's interesting is the number of the length of the longevity of folks that live at KNI. Last year, KNI celebrated its 60th anniversary, so it's been open for 60 years. And kind of at the bottom of the slide there, 19% of people that live at KNI now have lived there for more than 50 years. So essentially since, well, I don't know, some have lived there since we opened the doors. And they tend to stay at KNI rather than go into community settings. At Parsons, there's 159 individuals that live in 10 different residential units. Again, these are the buildings are subdivided to be have a more home-like setting with a dedicated staff. People eat meals together at the residential home level to have that smaller community. Last fiscal year, we discharged. I did get an update on this number from when we printed the slide, but there were 13 people that were discharged from Parsons and 7 were admitted. So unlike KNI, or a little different than KNI, there is some movement in the population. Either people at Parsons find a community placement that will work for them, or they're stabilized, they're having a problem in a community placement. They go to Parsons and get some additional care and therapy and look at medications and new treatment plans, and then they're able to go back into a community setting and live more on their own. So there is a little bit more transition of folks there. 39% or 40% of the residents have the severe, profound intellectual disability. So not as severe, but people that have some medical needs or behavioral needs that require that more intensive level of care that we can provide at Parsons. Parsons State Hospital also has on the campus a University of Kansas Center for Developmental Disabilities. It's a research campus for the University of Kansas. That the KU folks provide some community services to the Parsons and kind of Southeast Kansas area. Respite, they have a payee program for people that do community-based services, and then some coordinated resource ways of essentially case management kinds of activities. There's also an assistive technology project that operates out of the Parsons campus as well. This has been a long-standing partnership between Parsons and the University of Kansas, both to provide a training opportunity for students, but then also and research on intellectual disabilities and how to improve the quality of services for folks that have intellectual disabilities. That's a really real asset to to the campus there at Parsons and Southeast Kansas. Lauren, we talked about the 3 different treatment programs that operate on the campus. The psychiatric services serves voluntary as well as folks that are involuntarily committed to the hospital. You have to be referred by a community mental health center, and right now that's budgeted at 90 beds. We're holding the census there at 72. Because of COVID, to give us a little extra breathing room if we have to admit a patient that is either needs to be tested or COVID positive, that we can provide the right level of isolation for them while we get them tested and then get them through their initial diagnosis before we place them on a treatment unit. The state security program, we already talked about. It's budgeted for 230 beds. It's doing competency reviews and forensic evaluations. I don't know if it's on the slide or not, but we'll talk about during the budget. We've also got some functionality that we can do those competency reviews in a mobile way. So instead of having to send the inmate that a sheriff is holding in a county jail, we can go out to the county jail and do the evaluation that's needed there without having to transport the person to Larned. We have to admit them, hold them for 14 days for quarantine, and then do the treatment part. The mobile competency effort is a big time saver. It's been a challenge with COVID, but we'll talk to you some more about that as we go through the budget. And then the sexual predator treatment program, a little bit more detail about the program there of the secure environment that we have, and then providing treatment that reduces the risk of reoffense, and giving people folks in the program a path to reintegrating in the community. There's 239 residents in the inpatient program, and then there are 27 folks that are at 3 reintegration facilities. And one of those integration facilities is on the Larned campus, one's at Parsons, and one's on the Osceola campus. Those 27 individuals have progressed through the program through the inpatient treatment side and have gotten to the point where they're ready to live outside of the more structured setting. They're still living in a facility housing unit on a hospital campus, but they might have a job in the community or are working on finding their own apartment as they again progress through the program. And then there are 18 folks that are on conditional release in communities around Kansas that we monitor on a regular basis, but they're living on their own, working on their own, and then with some oversight by the program staff while they're on that conditional release status until they're completely released from the program by the courts. Right now, the reintegration facilities can house a maximum of 16 people per county. And again, we only have 3 of them operating, and they're not all at the 16 capacity. We've got 284 residents right now, and we think we're going to be pretty close to our total capacity to house folks in the next year and a half or so. We'll talk more about funding here in just a second. For Osawatomie, the campus at Osawatomie has been around for 153 years. There are several parts of the campus that we're working on maintaining as historically accurately as possible, given the long-term commitment that we've had to the Osawatomie community. It serves folks in their catchment area of 45 counties that goes all the way to Sedgwick County and then kind of diagonally up through the state. Right now, 53% of the patients at OSH and 82% of the patients in the Adair acute certified area have co-occurring substance abuse issues. So we're treating their mental illness, but they're coming to us with some other underlying substance abuse issues that can often confound their treatment course and discharge. Again, just like Larned, we admit people based on a screening by a qualified mental health professional at a mental health center or an order from a judge. We've got 114 licensed beds on the OSH side and 60 on the AAC side. And again, we keep the AAC census down from the 60 for isolation purposes in case we have a COVID positive patient. So that's Osawatomie. So here are the kind of 3 overarching issues that we wanted to raise for you as to think about for the hospitals. Number 1, right now at Osawatomie, there's a moratorium on voluntary admissions that's been in place since 2015. We had a lot of discussions last year and support from both the governor's budget and the legislature to move forward with lifting that moratorium. That effort involves building some community inpatient capacity, and there was funding appropriated for that activity to try to expand the number of beds that are available in community hospitals that could serve folks that we would otherwise admit to a state hospital. There's also some funding available on the capital improvement side to remodel a building on the Osawatomie campus to add certified beds to the treatment mix, so we can serve more people at Osawatomie. And the combination of those community resources and then the additional space at the Osawatomie campus, we believe we can lift the moratorium and start admitting people on a voluntary basis as well as involuntary. We'll talk more about that during the budget cycle. We did get a little bit of a slower start than we anticipated in some of the planning around that. We'll blame it on COVID because it was because of COVID. These are vacant buildings that weren't being used for treatment now. We were able to repurpose them for isolation and quarantine units, which was extremely helpful to have. available to us, but that did put us a little bit behind on the planning process going forward. In the sexual predator treatment program, capacity is the concern there. There's new patients or new residents coming, not every day, but that are in the pipeline, that are in the correctional system, that are coming out and will be civilly committed to the program. And then we've had a number of people also return. They're at the sexual predator treatment program, have some issue with that, end up going back to prison, and they're going to come back to the program. So we've got 147 on the campus at Larned now, with 5 available beds, and we've got 4 expected admissions during this first quarter of 2021. We try to move people through the program as much as we can, but that's a struggle. It has been, particularly since treatment has been difficult because of COVID and getting people on the campus to provide it. So capacity is a concern. We've also got a number of people, 23% of the residents, that are cognitively impaired. They have either a brain injury or a limited IQ, so they're difficult to treat in terms of meeting their needs and changing their behavior. So we don't anticipate that they'll move into community reintegration anytime soon, or are likely to. That bottles up the capacity. And then about 17% or so are high risk or medically infirm. People that are sick, they're aging, and they have the diseases that come with having multiple comorbid conditions or diseases of age that require specialized medical care. That's expensive. That's not as much of a concern. It's that these are also individuals that aren't going to progress through the program. They're not going to be successful in a community setting just because their medical needs are too high. And so that, if you take those 100 individuals out of the program, that doesn't leave a lot of additional space to make things work. So we'll talk to you some more about that during the budget process. And then finally, staff recruiting and retention. We've made a lot of progress in retention, particularly at Larned as the correctional. So on the Larned campus, there's also a correctional facility. They had a pay increase a couple of years ago. The governor, through an executive directive, was able to match those things for the direct care positions that would where we were in competition with the same candidate pool, essentially with corrections. That's been successful. We're finding similar concerns with our direct care staff at KNI and Parsons that are relatively low hourly wage, and we're competing with other healthcare settings for the same kind of workers, or even just community employers that are able to pay $13, $14, $15 an hour. And in many cases, that's an easier job than working at a state hospital with some of the patients that we serve. It's rewarding. There's a lot of value in the work that folks do at the direct care level, of what we call our mental health and disability techs. They do, but it's really hard work. And as a delivery driver, that's a difficult choice to make. So we'll talk to you some more about efforts that we've got in mind to keep recruiting and trying to retain the campuses where they are, and to have a viable workforce. And then we'll bring you some more information about COVID as well, and what our response has been there, but we can hold that for another day. That's a really high-level overview. We'll try not to repeat all of this. You certainly won't hear it from me during the budget hearings next week. The superintendents will speak with you about where they are and how things are proceeding. They're all for. I don't mean to set them up, but they're impressive people. They have been working incredibly hard over the last year to keep their staff motivated, to respond to challenges, work with limited information about COVID and what to do. And I've been impressed day after day with their creativity and their willingness to work together and bring resources to bear. We've had I think a real success story in maintaining our capacity, maintaining the health and well-being of our staff and patients at all 4 campuses. And that's been you've heard that from other hospitals and nursing homes, and it's all true. But you've got state employees as well that are going through that every single day and have for more than a year. So they won't toot their own horns as much. So that's my job. So thank you for your indulgence to let me do that today, and I'll probably do it again next week a little bit.
Very good. Thank you. Committee, I'm not just torturing you with this. You know, we're going to have these budgets next week, and it is very good information just to have this overview. Trust me, when you get the budget, we'll be swirling around. But Representative Ballard has a question, Scott.
Thank you, Scott. I legitimately have it. I was not trying to prolong to make my chairman happy, but state security program. We haven't talked a lot about the state security program.
Mm-hmm.
And I guess, how does a person get into the state security program?
That's a great question. One way is that it's an individual who is in a county jail that the court has decided is trying to evaluate whether that individual is competent to stand trial or stand trial for a crime they're charged with, and that they're able to understand the charges against them. So if the district court judge decides that there's an individual that's accused of a crime, they're in a county jail or they're in a jail, and there's some question about whether they understand the gravity of their offense or what they did, they can be referred to the state security hospital for a forensic evaluation. And our team then evaluates them to decide if they're competent to stand trial, or if they can have their competency restored, which means with some treatment for some length of time, that individual they might be incompetent at the time that they're referred to the hospital, but they could have their competency restored and then stand trial to go through the rest of the criminal justice process.
Okay, I think on one of our visits several years ago to Larned State Hospital, so if I have it correctly, we were looking at a wing and they're sort of locked into separate rooms, almost like a cell. Am I correct?
That's not uncommon. There's some other that they're in particularly on the security behavior unit. They are more secure there because of the risk of patient-to-patient injury and patient-to-staff injury. But I think I'll check for sure or make sure that Superintendent Dittman talks about it. But I think there are other room configurations, but this would be the highest security, and it would be a locked unit on the state security side.
Thank you. That helps. It dawned on me when I was reading it through that we really have not talked very much about that, or how long people stay, or, are they waiting for their trials later on or whatever. So we may, at some point, a little more information on this, I think would be helpful, because I don't even know how much we even budget for this. Does the county pay, or does the state pay, or whatever? So when I read it, it brought up a lot of questions for me, but thank you so much. Appreciate it. Thank you, Mr. Chairman.
Representative Lynn.
Thank you, Mr. Chair. I have two questions, and they're both specific, more to KNI and to Parsons. How are your needs changing as this population ages? They're having longer lifespans, which is a great thing. And then in addition to that, are you seeing an increased need to house new residents as maybe their caretakers, who are currently living in their community as their caretakers age?
Great questions. So on the medical needs, what we're seeing is, and we'll talk more about that during the budget hearings, but there are folks that they've got their disability, the disability that they've had their whole life, and now they're aging to the point where they've got other conditions around hypertension or diabetes or congestive heart failure that in some cases could be related to their intellectual disability. In some cases, it's just because they're 65, 70, 75 years old. And so it's sort of, at KNI in particular, there are parts of the campus that look a lot more like a nursing facility, where there is the home-like setting, there is that sense of community, but they're not able to be as active, not able to go into the community. So we're accommodating that as much as we can. One of the initiatives that the superintendent's implemented is to try to raise the level of medical of nursing care by the direct care staff, so they can be able to do some additional procedures. And Superintendent White could talk more about it, but they, in terms of breathing treatments and just kind of things that are a little more intensive, to try to get that again at the home level, so that they're better, more comfortable and able just to live a more normal life. But it will look a lot more like a nursing facility than a group home. In terms of needs, we do have some folks that are, as their caregivers age, that's looked at as an option. We've got a waiting list of folks to be admitted at Parsons. More of those, at least the last time I looked at the list, they're either youth or on the younger side of adults, 15 to 21, 22, that are experiencing some issues with behaviors that make their community placement challenging or living with their family challenging. So they need some additional support and training. So that's more common. I'm not aware that we have a waiting list or we're waiting an admission on anybody who's older or their caregivers are aging out. But we have talked about that as where would the state hospitals fit in those kinds of transitions as well, because the whole population is aging. So that's something to think about.
Further questions? Got to have a couple here. One, could you detail at OSH, certified beds versus licensed beds?
So on the Adair unit, that's the only segment of the campus that right now is certified for Medicare and Medicaid payments. So that's 60 beds that are certified. The remainder of the campus, that's 114 beds or so. They can't participate. We can't bill those to Medicare or Medicaid, so they're state financed. The two hospitals, so at Osawatomie, it's really two hospitals on the same campus. The Adair unit is certified by CMS and operates independently, has its own chief executive officer. They share a medical staff. They have their own nursing staff, but it really is a standalone hospital in the mind of the federal government for certification purposes. The OSH side is under the direct control of the superintendent and is a little, meets a lot of the same standards, but it just hasn't been certified by CMS. When we add this additional capacity related to the moratorium, the design is that will all be certified space, so we can bill that to Medicare and Medicaid, and we'll build it in a way that meets those requirements around the physical configuration, the standards that we're going to meet, the anti-ligature requirements to make the place safe for residents. So, but that'll all be certified space.
Very good, thank you. One other question, Ben's, your numbers are down. Have there been any salary savings because of that? Not
so much at KNI or Parsons. Our numbers are down, but that's helped us meet kind of other staffing shortages and other cottages and direct care areas. So it's helped. It's helped where there have been additional vacancies, particularly at Parsons. The need hasn't changed that much, so I think it's probably mitigated some of the other needs that we would have identified maybe for additional people or more funding. So I think it's been a cost deferred more than avoided altogether.
Okay, thank you. Committee, further questions? Anybody? Oh, Representative Helmer.
Yes, Scott, I want to thank you for all this information. And I want to say I was raised, my grandmother was a nurse at Winfield State Hospital, and my aunt was a nurse there. So I was raised around this type of situation. And this gives me great pain to hear this. If that's a good adjective, because there are so many of them, and it sounds like you're doing such a great job, so thank you. But I do want to know, sexual predator treatment program, how is that, is it being successful? Do you get to release very many of them? And when you do they get to stay out? Do you, I mean, how long is, do you have to supervise them forever, or what, how does that work?
We supervise them until they're released by the court. So they're civilly committed by a court to the sexual predator treatment program, and the only way they're ever, I guess, released from that is when the court determines that they've met all the conditions of their release and aren't a risk anymore. I'll pull the numbers to make sure that I've got them. It's not a very high number of folks that we've ever gotten all the way to the end and released from custody, although it has happened. And you can see, given we've got 240 or so in the inpatient, kind of the intensive part, there's a couple of levels of progression on the inpatient part. The reintegration facilities are the kind of first step outside of that intensive setting where people can be more involved in the community. They, like I said, they have jobs, they're out in the community. Those are all completely supervised. There's somebody going with them to make sure they're getting to their job and back. But the numbers taper off quite a bit as you get closer to being completely released from the program. So it's not a high percentage. I'd hesitate to expect to guess what it is, but there have been, as I recall, we have graduated folks from the SPTP, but it's not a large number given the total population.
Such a challenge. Thank you very much, Scott, and thank you, Chairman.
Committee, further questions? Okay, thanks, guys, for the help, and girls. It's not 5 o'clock yet, but I can drag it out if I, no. Thank you for being here, and thank you for that. You know, it's a 30,000 foot level. It'll be trial by fire next week when we do the budgets, but just keep some of these items in mind. Committee, a little cleanup here. We will start the budget process, budget hearings on Monday. And I've seen it a bunch of times, but I can't remember where we were starting. Yeah. You'll all get copies of these so that we'll know that, but yeah, we'll start out. Yeah, and this is the one that I just got at the budget meeting, and it doesn't have that on there correctly. I do have that one. Anyway, yeah, that's good. But we will, let me borrow that for just a second. We'll start out with some easy ones, healthcare stabilization. For those of you who don't know, we self-insure basically our physicians, and it keeps the cost of their liability insurance down by having this fund, and it's got a lot of money in it, and it's there for litigation and that kind of stuff. But it keeps the physicians, mortuary arts, that's pretty much a non-event, and it takes about 5 minutes. But, and then the guardianship program, which is a great program that we'll be going into in some detail, but it's not a great big budget. I think our portion is 50,000 or something like that. It's very small. But, and then we'll do, the way it will work is we'll do, the next day, we'll do recommendations for that, those budgets that we heard the day before, then we'll hear these other budgets that day, and then we'll do recommendations after the next day for those. Traditionally, it'll get a little more detailed when we get into the big three and stuff like that, where we'll take a couple of days for recommendations because it's just so much to absorb. But during this process, if you have any recommendations or anything like that, certainly come email me or come knock on my door or something, and we'll visit about those and see what that involves. So, Representative Ballard, anything I should add? Yeah. Would. I think, you know, it doesn't take, everybody knows we're in a budget constraint. And so our budgets are more than likely going to be fairly austere. And we'll try, if we do, or we do find a project, we're going to try to find money elsewhere within that same agency's budget to maybe shift the money around to fund something. One of the things that she's talking about, which it has not gone away, and I'll just kind of give you a big overview of this. The IDDD providers are in rough shape. COVID has not helped that one bit. We had a 5%, well, it wasn't a 5%, but I call it a 5% for all intents and purposes, increase in provider reimbursement rates. And it was a provider reimbursement rates for our ID and DD providers. And it was $8.9 million, brought down 11 or 12, $13 million in federal money. So it was like $22 million for those. We worked hard to get that through, and it was allotted. And we're going to take another run at that. That need has not went away. I know we're in these budget constraints, but that need has not went away one bit. As a matter of fact, it's gotten worse with COVID and that kind of stuff. So we're going to take another run at that. There's a bill that we may hear and then work, not us, but Appropriations Committee, and then vote it on the floor. You'll know all the details about that, and I would like your help in selling that to the rest of the legislators. We've got, you know, at some point in time, like we talked, people are going to think, what were you guys thinking when we don't have any providers to take care of these folks? Because they're all out of business because they couldn't operate. So that's just one of many that we're going to go through, and I know Representative Concanon is aware of the issues. So anyway, stay tuned, and we'll be working through this process, and it'll be fun. Certainly come to some of the more experienced folks. If you have questions, my door is always open also. If you don't understand something, you're responsible for asking enough questions to make sure that you can answer those questions if someone on the street asks you that question. So don't shy away from answering questions. Don't be afraid not to say, I'm not clear on that and you need clarification. Just make yourself very comfortable with those issues so that you can answer them fluidly. Yes. I'm glad you mentioned that because I tell you, let me just tell you a little story. I have railed, Representative Ballard has railed, all of us have railed on this wait list. And, you know, a lot of times folks, because we're legislators, they don't want to say you're an idiot, you know. And so finally, after we were doing there's 4,000 people on the wait list right now, roughly. I don't have the numbers yet. I'm waiting on those, but there's 4,000. We were doing 150 people a year, adding them to the wait list. And finally, it was really kind of funny because finally somebody said, look, don't you get it? We don't have the capacity to take even hardly the 150 that we're putting on there now because these providers are so strapped for cash, taking care of the people that they are. They couldn't take on much more than we do now because they just don't have the staff. Their turnover rates are outrageous because of COVID. Their liability insurance has went through the roof. I mean, they're faced with all these deals. Finally, those folks said, well, and then we started in on that. Well, to do the wait list, and actually the motion was made last year to do away with the wait list, $120 million 20 million a year. So obviously, that is not doable. But the thing that we have to do is we have to get the cart before the horse, and that is build our capacity in these providers so that we can start to look at the wait list. And we'll talk about that in depth, but other states have done quite a bit. I've researched it pretty intensive. And the way the wait list works is you have to accept all 6 services. You may only need 2, but you will not be accepted on there if you don't. Well, so, and that's how our waiver is set up. So we could apply for another waiver that would say 3 services, and that would take some people out. It's also going to take money, but it doesn't have to be all or nothing. And some states are set up where they do only have 2 services or 3 services, but it's a separate waiver, and they've went to CMS and done that. So we're in this process here of addressing the wait list. And I'll have a proviso in committee, in the Appropriations Committee, to study the wait list and go into detail, and probably an interim committee during the summertime to really find out what our options are as far as what these other states have done to try to reduce their wait list. So it's a huge thing. We're going to take a shot at it. Oh, that's okay. Feel free. Okay. Sorry.
I just was going to add to that another aspect is sometimes people will get their name on the wait list knowing that they don't need anything right now, but will in 7 years. And so we want to get those all divided out so that we know who needs what. That's right.
Exactly, because right now it is a 9-year wait to get services on the wait list. So a lot of folks are on there hoping that they get selected by 9 years, so.
And that was the concern that a constituent raised, was that, they had an IDD child who needed to get services, and they were instructed by JCDS to get on the wait list, like, when they were born, so they could access the services when they were, like, 10 or 11. So, yeah, that's really helpful context. Thank you.
Who are we assigning them to when we are choosing them to put them on a wait list? What organization, like
Well,
the state or DCF or who?
no, to a provider, but they.
So anybody?
They would go through, yes. It would
We have
be the
providers?
provider in their area.
Okay.
But first, the process is they're accepted into the waiver. And that's the funding source that they get, that we fund as a waiver, and there's 7 of them, TBI, brain, autism, all that. But we're particularly in this here, we're not talking about the rest of them. I think PD has a wait list of like 1,900 or something.
They didn't used to have one, remember?
Yeah. So physical disability, I do PD, but it's physical disability. But there's 7 waivers: autism, brain injury, frail and elderly. That's what he was talking about when you're talking about Medicaid in the nursing homes. That's the frail and elderly waiver. So what's that?
Sorry, it's frail and elderly for PACE. Just trying to put the pieces together.
It's totally different.
For
Yeah.
that, because, okay.
PACE is really keeping them from going into the frail and elderly waiver, because that's how they're accepted into the nursing homes for Medicaid to pay for them, is on the frail and elderly waiver.
We probably should cover that.
Well, we should.
Well, we probably should. What we're talking about now is really the fundamental of why it takes so long. You're not automatically just accepted to a waiver just because you apply. There's guidelines and how you fit in and what has to happen and everything else along those lines. But
So the legislator selects them first, and then we put them into that,
no, the legislature doesn't.
We have nothing to do with it.
nothing?
Well, except for funding.
We're trying to pay for it. Well,
Thank you.
It is complicated, but we will, that was one of our deals this next week. We've run out of time. We've got to go to work. But we will make sure that you're fluent in the waiver situation and all the ins and outs of it. I've got some information coming right now that will address those numbers wise and then the process for the waivers. So
We can ask Megan. Megan's relatively new, but yet she stayed there and she asked questions. Well, make some comments so that they'll get an idea of how they can learn it.
Just got to keep going. You just got to keep asking questions and learning. Yeah. I don't, sorry.
it.
I'm still learning too. I don't have it all yet either.
Certainly ask questions. Some of us have been around a little bit and we take things for granted, and that's not what we want to do. We want you to fully understand exactly what we're doing. Okay? All right, well, very good. Well, with that, committee, we are adjourned.